what I want to do over the next 30 minutes or so is just create a level of situational awareness. It will be a refresher for many folks. It'll be new information for other folks. But I think it sort of sets the stage for the conversation that we'll have today. At the end of the presentations, I want to keep it very simple. I think the things that I want you to be able to take away is to have a good assessment for what's the current state of maternal mortality from a broad perspective, from a 30,000-foot view, and from a state perspective. And then you'll know the details within your local institutions and your local communities. But hopefully by the end of the day, we'll see how these things sort of work together and what we can do to improve it. Specifically, I'll describe the findings of the Arkansas Maternal Mortality Review Committee and discuss some of the recommendations. I would direct you now, if you just Google Arkansas Maternal Mortality Review Committee, it will take you to the report and you'll see some of the slides. So what you'll see is a snapshot of some of the information, but it won't be all of the information. You can read the report and you can see what we found. And then you'll see some of the recommendations that we've made, some of the key findings and the key recommendations that we've made to reduce maternal mortality. And then the last thing will be to describe some of the active efforts that are going on within the state to improve maternal health. Power needs no introduction because they got us here, so we won't do a deep dive on that, but I will mention some of the other efforts that have been ongoing. And then at the end of the day, we'll be able to figure out how do these things work together. And I come to this from a lens of maternal mortality as we talk, but those numbers, that's a provocative position. You know, a mother dying evokes a visceral response in us all. And so as we're thinking about this, when I say mortality, I want you to always sort of think, but what about morbidity? But what about the mom who went home dramatically? And we will say, we can pat ourselves on the back and say, mom didn't die, or baby didn't die, but did she go home whole? Did she go home intact, mentally as well as physically? So those are the things I want you to think about as we go through the presentation. So I always like to begin with why. Why is this a subject that we're talking about? And, you know, there was some information a few years ago that discussed the implementation of a pregnancy checkbox, and it tracked the data that said that there was an increasing maternal mortality rate that could have been associated with the fact that there was a staggered implementation of a pregnancy checkbox. And while that may in fact be the case, you know, if we look at our definition of maternal death in the United States for 2019, 20, and 21, the checkbox has been implemented. So that's done. So I had to kind of modify my discussion about that because the numbers still creep up. 754, 861, 1,200 in 2021, and over 3 million births in the country per year. And these are small statistical numbers, but as I've said before, and if it's my wife, my daughter, my friend, my family, my patient, I really care very little about the total number. I care about this person and what could we have done here. So all of these lives are very important and we need to take effort. So that's sort of the level set. And if we look at our maternal mortality rate, what we'll talk about is deaths per 100,000 live births, as you can see that trend increasing as well. So this is sort of where we begin our conversation. So key facts globally, about 800 women die worldwide from preventable causes. Almost 300,000 died globally in 2020. 95% of these deaths occur in low or middle income countries. We are not one of those countries. But we are not exempt from the problem. We know that doing the right thing, skilled care during, before, and after childbirth can save lives. And you can see what the numbers are as we relate to developed countries versus lower income countries. Now, what is a maternal death? So the WHO will define a maternal death as the death of a woman while pregnant or within 52 days of the termination of that pregnancy without regard to the duration or site of that pregnancy. And we'll talk about a maternal mortality rate per 100,000 lives. So I'm going to kind of jump back and forth between this definition and another definition that we used when we're looking at maternal mortality. So I just want to point that part out. So this is one definition. This is a WHO definition. And if you look at how we do, before we get to a point of patting ourselves on the back, we can show where our maternal mortality rate compared to other developed countries. And you can see Netherlands 1.2, you can see United States, 23.8 per 100,000. Then if you can see in the teal, and I would say I thought it was just amazing that teal sort of correlated with that I guess that's teal. I don't know what that color is, but it kind of correlates with the colors that we have of our PQC. But you can see U.S. Hispanic maternal mortality rate, U.S. white, then U.S. Black. You can see that rate. And we're talking about in this situation, we are using sort of the same international definition. How do we define their income? You will use a factor like gross national income divided by the number of people. So when we are more affluent countries, this is where we are developed compared to the less affluent countries in the United States. It just shows that we have some work to do. So if you look at 2018, and I'm just going to point here, 18, what we're looking here, 18, 19, 20, and 21. Top line tells you the number of births total, almost 4 million births, over 3 million. The number kind of dipped a little bit, but hovers between 3.6 and 3.8 million births. And you can see the raw number of deaths. And I know it's a very busy slide, but this is pointing it out if you want to pull it up. It's a very quick report, and it's a very neat report from CDC. It's about 2 pages with about 3 pages of tables. And this is something I think you should have on your desktop as you're kind of doing your work to kind of refer back to. So this is maternal mortality in United States in 2021. So you can see here, this is a total, and what we're looking at is different years, 18, 19, 20, and 21. Broken down by the total, broken down by the non-Hispanic white, non-Hispanic Black, and Hispanic. And I mentioned 23.8 was our paternal mortality rate. And this is 2020. You can see we were up to 32.9 in 2021. And, you know, without getting into the numbers, I'm just sort of a plain, simple visual person here. What I see is a bigger graph that is significantly higher in non-Hispanic Black women, which is pointing out to that disparity that we know exists and has persisted for years. So, but in each group, you can still see that there's an increasing rate. If you were to look at maternity mortality rates by age, which is sometimes lost in these conversations, but as society changes and there's a delay in childbirth to later age, or if you were to look on, as my daughter calls it, the IG or Instagram or the TikTok or whatever it may be, you will think that people having children or giving birth at 45 or 50 is not without consequences, not without risk. And you can see here that for women, while they do not make up the majority of those births in those age groups, the maternity mortality rate in those age groups is much higher. So then if you were to sort of compound and have an intersection between race and age, then you may even compound that factor even more. So just to have context here. So I mentioned the definition of a maternal death. Now I want to talk about a little bit about a different set of definitions using the PMSS system. And what we'll talk about here is a pregnancy-associated death, meaning the death of a woman during pregnancy or within 1 year, regardless of cause. Now, what's the distinction? I said 42 days before. Now we're talking out to 1 year, okay? Or pregnancy-related death, which is the death of a woman during pregnancy or within 1 year from a pregnancy complication or some chain of events. Mom got pregnant, she had a baby or didn't, and within a year later, she was no longer with us. So this is a pregnancy related, something in that sequence of events led to her death. Now, pregnancy associated but not related would be a death within 1 year from a cause that is not related to pregnancy. So say a tornado comes through your town, hits a tree, the tree falls on your home, and someone dies. Did the pregnancy have anything to do with that? Likely no. Okay. And then we'll talk about the ratios again, back to setting per 100,000 live births, because how do we compare the number of births in Arkansas to the number of births in a state like California? A little different. So one city in California may have as many births as we do in an entire state. So a few years ago, we showed this slide. This is where Arkansas is ranked compared to other states across the country. The darker the blue, the higher that number. So you can see there's a little bit of work to do, and just kind of keep this in mind because we'll come back and I'll focus a little bit on our geography and you'll see how we're doing in our region. You can see the states that are doing better. And so part of the thing is that if you want to do better, sometimes it's better to ask people how they're doing better. Maybe you should call somebody from California and say, hey, can you come tell us what you're doing? That might be a good plan. So thank you, Don. Okay. And if you were to say, what's the variation within the states? And this is a slide that's from CDC. And so the next couple of slides, I want to give thanks to Julie Zalarados over at CDC and her team for sharing these slides with us. But this is sort of de-identified state data, all of the states plus Washington, D.C. So I showed you something, and I don't know exactly if this correlates with the last slide, but I will say California is over here somewhere, and we are over here somewhere. So from a few years ago, we would have been probably right about here. So obviously work to be done. So we have a maternal mortality review committee, and legislative efforts were put in place in the 2019 legislative session. And that led to the formation of two committees, the Arkansas Maternal Mortality Review Committee and a Maternal Perinatal Outcomes Quality Review Committee. And these were some initial legislative efforts that came as a result of meetings much like this to bring this attention to the people who can have influence and change policy. One of the things that legislation helped to establish was the authority to ask for the records to do the committee work and to ensure that folks recognize that the committee was doing work that was not, a couple of things to know about MMRCs. They're not a peer review process for an organization internally, so it doesn't replace that. It is not meant to be punitive. It is meant to be solution oriented and to get to a deeper level of understanding of what happened within a case versus us simply requesting a file of de-identified data that are numbers, and as a clinician will actually create more frustration with me because I'm like, what am I looking at? But I can understand the stories when I begin to do the records. And so the formation of that committee through the legislative support allowed us to ask your hospitals, and some folks in here may have received a letter from me saying, can you please send us your records? And what happens is those records come and we have an experienced former labor and delivery OB nurse who is our abstractor, and she will go through thousands of pages of records, upload the data into a data system called Maria, where we share our data nationally and their power in numbers because our numbers are relatively small, comparatively small. And then she will take that and bring it into a 3-page narrative of what happened. The committee, which is about 60% clinical, about 40% non-clinical folks, will sit around a table, which is, I am convinced, where all decisions are made and all significant decisions are made in the world. They get to a group of people sitting around a table. Okay, now what happened? That's how it always is. I used to think it was much more elegant, but that's what it is. And we sit around the table and we begin to ask the questions. And what are the questions that we ask? One, was that death pregnancy related? The big umbrella. Did she die within a year? What was the underlying cause of the death? Why do we all die? The computer stops, the pump stops. That's why we die. What was the underlying cause? What led to it? Was it she hemorrhaged? Was it she had a stroke? Was there heart failure? Then the next question is, was this death preventable? And this is always a tricky question because were there some reasonable efforts that could have been made somewhere along the way that would have changed the outcome for this mother? Let me rephrase it. Were there some reasonable efforts that along the way could have happened that would have changed the outcome for this mother, this family, this physician, this nurse, this team? Because that death, it affects us all. What were the critical factors contributing to the death? And what are the recommendations and actions that can be made that can that address those contributing factors? And then what's the anticipated outcome? Will this be if we do an action that says, let's educate on how to do CPR, that's a basic education, so that impact may be small. But if it's a large effort or a large initiative that occurs that changes the dynamic of how medicine is practiced, then that may have a much more large societal impact. So we want to give some assessment in terms of what that impact would be. So last year was a busy year. The MMRC, we initially started with a sort of a bootstrap effort, a mandate without funding, which is always fun. Start a committee and do the work. And we had a fantastic set of volunteers that participated on our committee. But last year, we did receive funding as a part of the Erase Maternal Mortality grant. And this was fantastic because now it puts us in a position where not only are we sharing data, but we have a better exchange and support from the CDC for our efforts. And I think this will be a benefit to the state. So it took a while to get there, but this is one effort that's occurred. So a few years ago, we would show these slides and Arkansas was sort of an outlier state without the support. So this has occurred. And other states have MMRCs and they're contributing to Maria. So what we're looking at here are ACOG, American College of Obstetricians and Gynecologists. We're region 7. Texas used to be a part of our region, but Texas said, you know, we'll just form our own region. Thank you. So they're their own region by themselves. And but so we're still friendly with them. Okay. So it comes to football, then we're going to have a problem. They join the SEC. That's a whole other thing. So we'll deal with that later. But this is Maria. And so now we are contributing as well as the other states. And you can see in 2018, we started the committee. We got authorization in 2019. The committee first met in 2020. And we had to stick a line, pin in the sand. Where do we start reviewing death? So, this has been occurring for a while, but we just started with 2018 and 19 data. We recently completed review of data for 2020. And now that we're having a larger amount of data available, we'll be able to share more information. If we have a small number of deaths and we share too much granular information, it becomes quickly de-identified because everyone will know what happened at that case and you'll recognize the hospital. But now that we are at 3 years, you'll begin to see a little bit different data. But this is, I want to share what we know about Arkansas and what we know about the states around us. So for these years, we had 251 pregnancy-related deaths in our region. Okay, now the numbers are starting to get a little bit larger here, and this gets a little bit more personal. And if you look at what are the 3 most frequent underlying causes of pregnancy-related deaths in ACOG District 7 among non-Hispanic Black women, that's a mouthful, but I think I've defined underlying causes. I've described District 7, non-Hispanic Black folks, we know what that is. And here are the causes: cardiac and coronary conditions. Okay. Which when a few years ago, when I started to see this number, it really surprised me because I was expecting, going to be preeclampsia, hypertensive disorder, stroke, hemorrhage. So cardiac and coronary conditions. 1, cardiomyopathy, embolism, thrombotic events, and hypertensive disorders. Okay, interesting. Work to be done. Most frequent underlying causes of pregnancy-related deaths in District 7 among Hispanic persons: cardiac and coronary conditions. I think we're seeing a trend here: hypertensive disorders, infection. Okay. All right. 3 most frequent underlying causes of pregnancy-related deaths in ACOG District 7 among non-Hispanic white persons: mental health conditions, hemorrhage, cardiac and coronary conditions. So what do we mean by mental health conditions? These include suicides, unintentional or unknown or overdoses. Okay. So this is what we're seeing. So now this is for a region, and we'll begin to get a little bit more information on our state. So I think for me, this begins to drive a question like, how do we screen? How do we select who is going to be tested for substance abuse? Once we identify, we ask the question, we've screened through the questionnaire, what do we do with the information? What are our resources available when we say, yes, you have a problem? And I was telling my colleague, Dr. Riddell, I said, sometimes I feel like a medical student when I'm like, oh, I made the diagnosis, my work is done. I'm like, no, what do you do about it? And so that's the challenge. So that's a little bit of perspective. Now let's get a little bit more specific to Arkansas and some of our findings. So each year we could produce a report and we submit to the legislature, which was one of the requirements. And in 2018 and 19, this is a summary of those 2 years. In 2018-19, we had 73,000 live births. We had initial pregnancy-associated deaths that were reviewed by the staff was 71. We excluded 17 for various reasons, and we came down to about 54 that were pregnancy-associated deaths by committee, reviewed by the committee. I want to say that if, for example, we have a patient who is from Arkansas who dies in California, she is our patient for review. Okay. If we have a patient from California who dies in Arkansas, while we might review it to know what happened within our system, it doesn't really count to our numbers. But because our numbers were small, we did review some of those because, you know, if there's a trend or if there's a signal that pops up at my hospital because I don't really care where she was from, it's like we may have a problem there. But know that that's why the numbers sort of jump around a little bit. And we had a few folks, so you see some that were not Arkansas residents, some that were not pregnant within the time frame. So between 2018 and 19, we had 54 pregnancy-related deaths, and our ratio was 73.7 per 100,000 live births. This is this is the large number. This is the broad number. What were our causes? As determined by the committee, the top underlying causes were cardiomyopathy and cardiovascular conditions, hemorrhage, hypertensive disorders in pregnancy, infection, and then other causes. What was the breakdown? You can see 43% were pregnancy related, 37% were pregnancy associated but not related. And then we had about 20% that we really weren't able to determine the relatedness. So why would something like this happen? If I have a patient who has a known history of depression who's coming into pregnancy and this depression is suboptimally treated, or the patient develops a postpartum condition or that is not, I'm just using depression as an example. And now she goes home and there are 3 children and poor social support and her depression is worse and there's a lack of mental health services available. And then someone finds her hanging in her bathroom by her bathrobe belt. Did the pregnancy start that? I don't know. Maybe that pushed her over the edge. I'm going into a rabbit hole here, but, you know, maybe if she wasn't pregnant, if she didn't want to be pregnant, you know, that would be an issue. So effective contraception, you know, at the time of delivery, you know, immediately may in fact be beneficial to her if there were resources available. So just things to sort of think about. I don't have all the answers to these questions, but I hope to just sort of leave you with some things that you can begin to ask within your system. So we look at pregnancy-associated deaths by race and ethnicity. In Arkansas, for example, 19% of all births were to Black non-Hispanic women, but in that group, pregnancy-associated deaths, Black women made up about 37%. So that's when you begin to see that slide where you start seeing that disproportionate number. If you were to look at it by age, this is not unlike what we have seen across the nation. Pregnancy-associated death increases with age. Women ages 35 and older had a 6 times the mortality ratio as women who were younger than 25 years old. How do you use this information? Obviously, I think we use it in counseling. We use it in education. You know, I use it when I'm having conversations with my friends and family. You know, if I have a niece who is contemplating a childbirth at 42 or something like that, you know, that may be a factor. If we were to look at the pregnancy-associated mortality ratio in Arkansas, you can see the disparity here. I won't read all the numbers, but I think you get the point that we're making. And then if you look now more to the pregnancy-related numbers, interestingly, with these 2 years, and this is sort of we have lived small numbers, but in the epidemiologists give me the data, and this is what we have. We had a higher rate of pregnancy-related death in our Asian mothers, which was 3 times as high as in white women in the state of Arkansas, which obviously are not making up a large number of births, but this is sort of the statistical assessment of it. Now, as we get a little bit next year, if I'm invited to share this information, I think I'll be to a point where we can tell you what the raw numbers are and a little bit more specific information. But right now, this may represent 2 or 3 patients. And then all of a sudden, somebody in this room would raise their hand and say, I remember what happened there. So the question is, though, what was the preventability? What was the preventability? A few years ago, combined data from CDC, from Maria, would say that the number was about 66% of those deaths were preventable. Then I think last year, 2 years ago, I think the number went up to about 82% of those deaths were preventable. From what is preventability? Some reasonable effort. And then when our committee reviewed all of the deaths and we used the decision forms, we felt that 91% of those pregnancy-related deaths were potentially preventable. And that begins to sort of stick at you. Now, when we start talking about preventability, I think one thing to keep in mind is when we're saying preventability, that finger doesn't direct solely at the providers. This is not a statement to say that hospitals, St. Elsewhere, just did something wrong. Because I think that was initially my immediate defense. So what are we going to find? What do we do wrong? Or what is the system doing wrong? What we find is that there is preventability that is often shared across the spectrum. There are preventable efforts that could have occurred from the patient and family, things that they could do. There are certainly things that we in the healthcare field that the facility could do, or things that the hospital could do, or the providers could do. Or there are things that the system could do, and there are things that the community could do. So when you're sitting here, I think we are two audiences. We're probably all five audiences in different groups. Collectively, we're representing systems, hospitals, providers. So that's three groups right there. We are all products of the maternal health system, right? We were all born, so we're there. We're all going to go back to our community. So we actually will be able to take information and share this and hopefully influence it. But that's where the efforts for preventability can occur. So what were the key findings of our report? Between 2018 and 19, we said 73.7 deaths per 100,000 was our ratio. The top underlying causes, as I stated, were cardiovascular, hemorrhage, and cardiomyopathy. We mentioned the disparity, and we mentioned the preventability. So what are some of the key recommendations? One, I'll just point out number two. We said facilities should implement evidence-based safety bundles through the Alliance for Innovation on Maternal Health. AIM is a data-driven maternal safety and quality improvement initiative based on consensus-based practices to improve maternal outcomes. That's a mouthful, but basically says we should use evidence and get on the same page. That's what it means to me. Facilities should work to eliminate discrimination based on race, cognitive status, disability, a host of things. Policymakers should increase funding to increase and expand the number of inpatient and outpatient facilities for treatment of substance use disorders and mental health disorders and other prior, during, and after pregnancy. One of the other recommendations we made in the year prior was that states should explore efforts to expand access to effective contraception, specifically efforts to provide support for immediate postpartum long-acting reversible contraception. I'm encouraged to say that I believe that was actually in this year's legislative session and has moved through the House and through the Senate. And what I was told is moving to the governor's desk. So that could be an impact. So that's some of the benefits that we've actually seen. So those are some of the recommendations, and those are some of the actions. So as you go to the vision board, put your wish list. I mean, because we will gather this information, and we're trying to get that to where the group of people sitting around the table in a big shiny building with the domes who can actually make policy, or the big people who have the nice wood table in our respective facilities in the doors that I rarely get a chance to go behind. Okay. Now, more specifically, what are some of the things that we can do? From the committee's perspective, we are not much of an implementation arm. We are gather information. Here's where we are. Here's what we found. But one thing I know that we can do is to listen. And that is listen to our patients. I've seen several, there have been several, last week was Black Maternal Health Week, and we did a couple of screenings of a documentary called Aftershock, and which is a great documentary that takes you through the story of two families whose the mothers died within childbirth. And there was a theme that you could kind of hear in that documentary, and we all know it, and that is they just wanted to be heard. They wanted to be heard. The patients wanted to be heard. And I think if we think about our own experience with our patients, there are times when, if you come through a busy L&D or a busy clinic, there's a lot of pressure, and you can see if we're not careful, we can get on an automatic pilot and we don't listen. But we do know that listening can make a difference. And one campaign that we have been in support of is the Hear Her campaign, which addresses pregnancy-related conditions. And if you look to the right, there is a urgent warning signs sheet. And so I don't think that QR code is big enough for you to scan, but we have these in our clinic. These are in every exam room. They are on the elevators when patients come in. And the idea is teaching patients and families how to advocate for themselves. So when that patient is complaining of this symptom, that don't dismiss it. So if that mom is, 4, 6, 3 weeks out and she's complaining of this headache that's not going away. And if to the uninitiated, somebody may think, oh, well, it can't be preeclampsia because that doesn't happen. Well, it can happen, and that could progress to other things, but there may be more. It may be psychiatric issues. It may be thoughts of hurting yourself. It may be difficulty breathing, so a host of other things. So the Hear Her campaign, I think, is something that really everyone should be familiar with, and this information should be shared widely. Now, what I want to do is turn attention to, that's sort of where we are, but I want to turn attention and introduce a few things that are going on within the state. We mentioned the goal to establish some committees. So in preparation for this, you start searching, you're going back, and I found an article from the Gray Journal, which is a journal that is in obstetrics and gynecology, and I found an article discussing the goals of the Angels program, and this was back in 2007 or 8. And so we're not new to this topic. We're not new to these efforts. But so that effort convened meetings in this room over a decade ago, which have sort of led to this. So Angels was at the forefront of a lot of things that we've been trying to do. And then we moved forward, and we'll fast forward to 2019 with the legislation and formation of the PQC. Our first sort of stab at getting attention around these topics was our Maternal and Perinatal Outcomes Quality Review Committee. I did not come up with this acronym. In fact, it is the most clunky set of alphabet soup that we've ever had, so I won't take credit for it, but I'll take responsibility for it. We have begun, that's came out of a program looking at perinatal regionalization. So this has sort of been, I'm going to say shelved, but because other things have been happening, we haven't met as much right now because a lot of things happen within the past year, and we'll look to sort of bring it back online within the next few months. And at the core of that was 3 subcommittees looking at education, and we've promoted things like making folks awareness of our rising syphilis rates within the state, making folks aware. We've had discussions regarding centering and pregnancy, making folks aware of what those programs were and the impact that they could have, because there wasn't necessarily a forum for folks to do this, and we would get representatives from the delivering hospitals. And then next is to expand and get back to our site visits to do designations of levels of care for not only our NICUs, but also for our labor and delivery units. So that has been on. It's not gone, but everything is sort of being shuffled and redesigned and hopefully unified. Next is to the kudos of great implementation scientists and people who have perspective and vision from other states. It's always good to see folks come in and help us develop programs. One program that you will begin to hear more about is Primrose, which is a funded program for the state that is going to look to do several things that are going to address data needs, health service availability, gaps in services, and ultimately the goal is to reduce these disparities. So this is what these initiatives, we've seen them from a national level, from the Surgeon General, when Surgeon General Jerome Adams put his blueprint out back in 2018. We've seen it from the White House last year. So everyone is talking about the same thing. Now what we're trying to do is move to actionable efforts, and these are some of the things that are going on. So with Primrose, we'll look to convene a maternal health task force, which will help to formulate a plan. Another group of folks sitting around a table. We're going to look to contribute to the regionalization of perinatal care. We've had some efforts there. Look to deliver evidence-based group prenatal care to disproportionately affected patients in maternity care deserts. If you look at the March of Dimes report, I mentioned our maternity care deserts. And so I think just doing the status quo, doing the same thing over and over again is not, this is why we're here and where we're at the level that we are. So there are opportunities to be a little bit more strategic. So deployment and creation of a centering program in certain regions of the state could be very impactful. And then preparing emergency providers in rural areas to respond to obstetric emergencies through simulation training. We do not have, every hospital is not a delivering hospital. Not every hospital has an obstetric services provider. A patient in distress who is hurting and not feeling well in the middle of the night sees bright lights and that cross that says, I'm needing help, and that's where I'm going to go. I don't know what your level of care, so if they show at the Arkansas Heart Hospital, I don't necessarily expect them to be able to do all of the obstetric services, but I do expect them to have some reasonable recognition of what could be going on. And it may just simply start by asking the question, have you recently been pregnant? Okay, not everything that shows up is going to be specific to the services that hospital offers. AIM. We, as you can see now, and I'm sure you'll see this slide later, I'm putting slides up that I'm proud to show that are filled in, because when we were sort of the outlier, not part of the colored map, it is good to say that we are, we're contributing to the national conversation, and we are learning from partners nationally. So the Alliance for Innovation on Maternal Health, we are now an AIM state. So Dr. Sanford said we're working to become an AIM state. And no, we are now an AIM state. So that is great. And we'll hear more about that a little bit later. And then most importantly, perhaps most importantly, is the Perinatal Quality Collaborative. So you can see that we received funding for establishment of the Arkansas Perinatal Quality Collaborative, which we are going to go into detail throughout the day. And collectively, now that we have all of these folks and I think it's very appropriate that we have silos that are right outside of this building. So metaphorically, what we will do is help to break some of these silos and work together to improve maternal health. So how I feel is that we have been talking about it. I have modified the presentation because depending on the audience that we're giving or talking to, raising attention was an appeal to emotion and an appeal to heartstrings, and look at how bad the problem is and look at why it matters. This is the choir. You are the informed audience. You know why it matters. So you are here. And so in many ways, I feel like now we've been the dog who's been barking at the car. Now we've caught it. We got everybody's attention. We asked for resources. We have resources to begin to do certain things. Now, what do we do? So I begin with why and I end with why. I mean, you never leave without asking for something. My ask is a call to action again, because the first time I think we had this conversation, it was like maternal mortality, a call to action. Now it's maternal mortality, a call to action again. Join the PQC, share your data. Let's improve the healthcare for women in Arkansas. Thank you.